So in our previous video, we talked about blood pressure. Let's kind of recap what we said. We said blood pressure was just the blood pressing against your vessels, right? And we said it was equal to about your cardiac output, the amount of blood you push in those vessels. That makes sense. What is cardiac output? That'd be your heart rate times stroke volume. We're going to repeat it so much times you know it cold, all right? I always like to repeat kind of difficult concepts just to reinforce them. And by the time we're done with this, you're going to know them all cold. So that's our cardiac output. And you might say, well, stroke volume is made up of preload, which is basically the amount of fluid, so fill fluid. Afterload, which was basically resistance. And then we had, of course, our contractility. No problems there. And we said that preload, the amount of fluid, will affect the blood pressure. If you have a lot of fluid in here pressing against your blood vessels, you're going to have a lot of pressure. Have a little bit of fluid, have a drop, not going to have a lot of pressure. So increased fluid equals increased blood pressure. Decreased fluid, decreased blood pressure. And we said that our organs can measure this and respond to this, especially our kidneys, via the RAAS pathway. The RAAS pathway. I'll put the video, again, in my description. I went in the RAAS pathway during our kidneys video. I won't go over it here. Afterload was resistance. And we said the main component of afterload is the size of the lumen. You have a very narrow lumen. It's going to be very difficult to push that blood through. So, all right, narrow equals high blood pressure. If you have a nice big wide lumen, lot easier to pressure drop. So dilated equals low blood pressure. Contractility, we said the main cause of contractility or the main player in this was sympathetic beta 1 activity, right? Sympathetic beta 1. And that caused increased heart rate, increase contraction, and all that will increase your blood pressure. And if we want to stop that, we have our parasympathetic. And that just does the opposite. Lower heart rate, lower contractility, lower blood pressure. So this all plays a role in blood pressure. And in this video, we're going to talk about high blood pressure. If we have high blood pressure, we're going to want to work on these factors to kind of reduce them. All right, we're going to work on our preload with drugs that work on our RAAS pathway. These are going to be your ACE inhibitors or ARBs. All right, again, it'll be in my notes, in my video of when I talked about the RAAS pathway. I won't talk about them here, but just know we have drugs that work on this pathway. We have drugs that work on this contractility pathway, right? We're going to want to stop this sympathetic beta 1 activity because that raises our blood pressure. And what do you think we give? We give beta blockers. Makes perfect sense. And there's some overlap. Beta activity also works on your RAAS pathway. I mean, there's going to be overlap. They have the same common goal to raise your blood pressure. So your RAAS pathway will get activated in low fluid and also in beta sympathetic activity. So I'll also write some RAAS activity. But for our purposes, we're really talking about lowering our sympathetic beta 1 heart rate and contraction. And when you give beta blockers, that's exactly what you do, and you kind of reduce that blood pressure. Some side effects you should know. A big one is erectile dysfunction. Any drug that causes erectile dysfunction, you gotta know cold, because men aren't compliant with these drugs. All right, they can have blood pressure through the wazoo. They can be like stroking out, but if it causes erectile dysfunction, they won't take it. So no erectile dysfunction. There's some controversy whether or not this actually causes it. It's not your worry. They're not going to be like, what's the latest PubMed article on this? Just know that it causes ED, as far as we know. It can also cause bronchoconstriction and difficulty breathing. Why is that? Because you have beta 1 activity in the heart, you have beta 2 in the lungs, which causes bronchodilation. Helps you breathe. Well, if you give a beta blocker, it might not be specific to the heart. It might also block that bronchodilation. So you get bronchoconstriction. You can't breathe. Bronchoconstriction. So it's contraindicated. All right, contraindicated in people like asthmatics. I've gotten a great question on it because of the bronchoconstriction. I got a great question on it. Talked about someone with asthma that had high blood pressure. What drug do you avoid? All right, you avoid beta blockers. Or they might take it one step further. The doctor didn't want to prescribe this drug. What did that drug do? block beta sympathetic activity. Okay, so they just want you to know that you don't do it in asthmatics. You don't give it to someone that uses cocaine. Cocaine activates your alpha and your beta receptors. And if you block beta, then you only have alpha left. You only have alpha left. And alpha does a ton of things. It also causes vasoconstriction. And if you have unopposed alpha vasoconstriction, you can have so much vasoconstriction you get a heart attack. That's why cocaine causes heart attacks. We'll talk about heart attacks in a second, but don't give it in cocaine users. So we'll talk about someone, what did I usually talk about? Someone has tachycardia, you look up in their nose, they're bleeding, they have white marks, cocaine user. Something that's not really contraindicated, but you gotta be really careful is people, so I won't put it near the contraindicated pile, but hypoglycemic patients. Hypoglycemic patients. Because in hypoglycemia, your blood sugar drops, your body panics, right? And it activates a sympathetic activity, it increases your heart rate. You go into basically a panic mode, fight or flight. And if you block that sympathetic activity, your heart rate drops, your symptoms aren't really being shown, and so it kind of masks that. It makes it harder to detect, right? And so people can go hypoglycemia, you don't really detect it, and they die. So just be careful with that. Have been asked that before, just be careful with it. So we talked about contractility, we talked about our RAAS pathway, let's talk about our afterload. Let's talk about our afterload. Well, if we want to reduce blood pressure, what are we going to do? Are we going to vasoconstrict? No, we're going to vasodilate. Make our lumen nice and big. And by making it big, lowers the pressure. So how do we dilate our blood vessels? How do we dilate our blood vessels? Your blood vessels are smooth muscles. Smooth muscles. Draw out our smooth muscle cell. And in your smooth muscle cell, you have your myosin, actin complex that causes a contraction, right? If you want to know why, look at my MSK videos. And if it's active, it has a phosphate on it. So we're active. You take that phosphate group off, it just becomes myosin plus actin without the phosphate group. And that is inactive. Inactive. You want to activate it? Put that phosphate group back on. All right, so it's a little cycle. If we want to contract, then our calcium channels open, our L-type calcium channels open. Calcium goes in, binds to a protein called calmodulin. So calcium plus calmodulin, and that will activate myosin light chain kinase. What a perfect name. Kinase means an enzyme that puts a phosphate group on. Phosphate group on what? Our myosin. So it puts a phosphate group on, and now it is active, and you contract. Now what do we want to dilate? Relax. Well, nitric oxide will come in, activate GTP to make cyclic GMP. And cyclic GMP will activate our myosin light chain phosphatase. What a fitting name. Phosphatase is an enzyme that pulls phosphate groups off. So you pull that phosphate group off, you inactivate it, you relax, you stop that contraction. So let's go back and talk about our afterload. We have drugs like calcium channel blockers. This blocks the side, no contraction, nice dilation. We already talked about calcium channel blockers in our arrhythmia videos. Remember we said there are two kinds. You have your dipines and your non-dipines. And our non-dipines work on our heart, great for anti-arrhythmias. And our dipines work on our vessels. That's what we're trying to do. Relax those vessels. So these are going to be our dipines. Our dipines. And they block this calcium, vasodilate. Hopefully no problems there. Let me make some room. You can have hydralazine. What the heck does hydralazine do? Increases cyclic GMP. Cyclic GMP. Goes through this pathway, takes the phosphate group off, and activates your contraction. Relax. Perfect. Perfect. They want you to know that it targets your arterioles mostly, which is great because then we say arterioles are the place where you find the most resistance, the most pressure. Relax those, reduce that pressure. Some side effects you should know. One that they love to test, many, many times. This is one of the few drugs that cause drug-induced lupus. That's your antihistone on labs. That's your lupus signs on physical exam, so the butterfly rash, all the lupus signs. So let's try and make a step-like question. Can you think of a step-like question? Pause the video, try and make a step-like question. Give you a second. So how about a person with high blood pressure, they give them a drug, develop the malar rash, all that stuff, and then they ask, what do you expect to find on labs? Antihistone. Right, so that's how they like to ask it. Last one, nitroprusside. This is a chemical that breaks down into nitrogen oxide. And then, I don't know why I call it prusside, maybe there's some chemical thing that I don't understand, but it breaks into cyanide. Breaks into cyanide. And the NO will cause a dilation. The cyanide, you need to know side effect is going to be cyanide poisoning. Cyanide poisoning. Okay. How do you treat cyanide poisoning? In my respiratory videos, you should know. If you haven't, just flag it and come back to it. But pause the video and answer how you treat cyanide poisoning. All right, give you a second. Okay, let's move on. These are all drugs to reduce your blood pressure. Reduce your blood pressure. If you have high blood pressure, we call that hypertension. Hypertension. Let's just talk about hypertension for a second. Hypertension. High blood pressure. Hypertension is defined as 140 over 90. And there are many factors that play a role. There are some non-modifiable factors, things you can't change, like your age, like your family history, like your race, especially seen in the black population because they retain salt and water more. You can imagine if you're in a scorching environment, you want to retain more salt, retain more water. And that just increases your preload, increases your blood pressure. So these are things you can't change. These are some things you can change. Smoking, food, our diet. So if you eat a ton of salt, eat bad foods, you can just increase this, all right? So, all right, exercise also. If you exercise, you can reduce that blood pressure. So these are all things we can change. Now, 90% of it is just essential primary hypertension. 10% is secondary to something. Secondary to something. Usually secondary to some sort of renal problem. Some sort of renal problem. If your kidneys don't get enough blood, they will freak out and activate the RAAS pathway to try and get more fluid in there. So if there's a problem with the kidneys, then it can basically cause over-activation of the RAAS pathway, and you get secondary hypertension. So, all right, kidney pathology. Kidney pathology. One of them they like you to know is fibromuscular dysplasia. This is dysplasia of fibromuscular tissues. And so you get these little narrowing of your renal vessels. It looks kind of like beads. There's a great picture in first aid in my notes. The vessels look like beads, all right? And that narrows the lumen. Your kidneys don't get enough blood. They freak out. They activate RAAS uncontrollably, and you get increased blood pressure. So think of this in a young woman who has really high blood pressure. You're like, that doesn't sound normal. I mean, this is a young person, they shouldn't have high blood pressure. So you give them blood pressure medications, and it just doesn't work. It doesn't work because there's some sort of underlying pathology that you're not addressing. So, all right, refractory to two meds. All right. So these are all things that cause hypertension. Why is blood pressure so bad? Well, I actually like the term hypertension a lot because it demonstrates a point. You have a lot of tension on your blood vessels. You have a lot of tension in your blood vessels. You can imagine if you have a lot of force pushing those blood vessels, these blood vessels can pop. They can burst. I don't know if that's a scientific term, but all that blood can leak out. You can hemorrhage. And if there's tissue at the end of this vessel and all the blood's leaking out and hemorrhaging, are you going to perfuse that tissue? No way. You can bleed out in your brain, hemorrhagic stroke, you can bleed out in your eyes, retinopathy, bleed out anywhere. The sheer tension force on your blood vessels will pop them open. And even if you don't completely pop them open, I mean, it's not benign, there are some other things like dissection. Vessel dissection, that just sounds terrible, right? So let's draw a blood vessel. And we said our blood vessels have 3 layers, right? And the inside layer is called the intima layer. Right? Then you have your second, medial layer, and then your outer layer. So blood, if you have really high pressure, can rip through this intima layer, intima layer, and blood will collect here. Right? Here's your second layer, here's your third layer. We call that a dissection. You're dissecting the intima layer. Dissection. And it happens a ton in your aorta, so we call it an aortic dissection. That just doesn't sound good. Are you going to have pain? Is that going to hurt? That's going to hurt like crazy. So you're going to have pain when it dissects your intima. And depending on where in the aorta, if you know your aorta is branched into its different vessels, you might have unequal blood pressure, all right? You might have blood going to your right side just fine, but then all the blood dissects through here, collects here, and then you don't get enough on your left. So you have unequal blood pressure. Blood keeps collecting, widens your vessels, widens your structures, causes widened mediastinum on chest x-ray. Widen mediastinum. They love to ask this. Someone with tearing chest pain, you do a chest x-ray, you see widened mediastinum dissection. I've probably gotten like 5-6 questions on this during my course of taking steps. So know this very, very, very well. There are 2 types. There's type A, which is in your ascending aorta. So A for ascending, A for type A, I guess. You have to do surgery for these. There's a type B that's a little bit more distal, a little bit further down. So I'll write distal. So maybe it'll be further down here. So you dissect through your inner intima, blood collects in here. You get a dissection that's a little bit further down, a little more distal. This, you can do surgery. You can also do beta blockers to reduce that amount of contraction, reduce that amount of heart rate, reduce that stress, and kind of alleviate that for a while, but eventually you probably need to do surgery. So it's associated with hypertension, name of the game, associated with also things like connective tissue disorders, like Marfan's. All right, Marfan's. If something's wrong with your connective tissue, if your vessels aren't built as strong as they should be, you can dissect right through them, right? So it shouldn't be too hard to remember. Seen in connective tissue disorders like Marfan. Also seen in bicuspid aortic valves. The mechanism is not quite known, but just keep that in the back of your mind. Just in case they ask it, you can be like, bicuspid aortic valve. All right. That's dissection. You have something else. You can have something else. Here, all the blood pressure is pushing against your vessels, and you get a little outpouching. You don't cut through the intima. You don't dissect through any of the layers, but you just kind of push and outpouch the blood vessels, and you get this little outpouching. We call this an aneurysm. An aneurysm. And you can feel this. You can feel this little outpouching, and it'll feel like a pulsatile mass. Sorry, pulsatile mass. They love to ask where are aneurysms found. They are usually found in your abdominal aorta. Your abdominal aorta. Aorta. Why? Because your abdominal aorta has less elastin. That's our structural integrity part, right? And it has less vasovasorum. That's the blood vessels that actually supply your smooth muscle cells. So you have less supply, it's weaker, it already has weaker structural support, easy for it to just outpouch, get full of blood, okay? And if it's a little bit higher up, we call that your thoracic aneurysm. That's not normal. I mean, here you should have plenty of elastin, you should have plenty of vasovasorum. So if you see a little bit higher up, if you see a thoracic aneurysm, you know something's wrong. You can see it in tertiary syphilis. Syphilis, the bug likes to destroy vessels. Destroys your vasovasorum. You destroy your vasovasorum over here, then it's just like down here. Doesn't have that support, you can have a thoracic aneurysm. And then when we already talked about connective tissue disorders like Marfan's. You're just born with bad connective tissue. It's born defunct, so you can have these weird thoracic aneurysms. Questions I've gotten on Marfan's, super simple to recognize, super easy, but then they try and trick you with some terminology. When you're not making that normal connective tissue, instead you get cystic destruction and degeneration that kind of take its place. And so they'll talk about someone with a thoracic aneurysm, someone with Marfanoid habitus, really long arms, all that stuff. And then they ask you, what's the mechanism? Why are they having this thoracic aneurysm? It's due to cystic degeneration of the media. Okay. That's a little terminology they like just to confuse you with. Let's say someone has a pulsatile mass and then later they present, they still have that mass, but now they're in incredible pain. What happened? That mass ruptured, the aneurysm ruptured. Surgery right away. That is aneurysms. These are effects. These are less common effects of high blood pressure. In our next video, we'll talk about more common side effects of blood pressure like atherosclerosis. Okay, so stay tuned for that. See you next video. Thanks.